Now, gastric biopsy interpretation is today's topic. Now, gastric biopsy, as you know, is it is becoming more and more common with the availability of more gastroenterologists in our system. More and more people are doing DMs, and the endoscopes are penetrating, becoming available everywhere. So, gastric biopsy is gradually becoming one of the method which is being followed by many clinicians, especially the medicine people, the surgery people. They are doing endoscopy, and we are getting more and more specimens of endoscopic biopsies of the GITs. Now, endoscopic biopsy, it provides an evidence of chronic gastritis or peptic ulcer in patients, and even people with non-ulcerated dyspepsia. The endoscopic biopsy is becoming more and more common to assess the Helicobacter pylori status. As you know, there are two kinds of gastritis. There is those due to Helicobacter pylori and the other causes, the autoimmune variety, and also to grade the gastritis and report the other forms of gastritis. And biopsy is indicated to assess the healing and to differentiate between the regenerative changes and any dysplasia, any precancerous conditions, whether they have arisen. You have already received the Sydney system paper, and the Sydney system requires that the biopsies be obtained from 5 locations in the stomach: the greater, the lesser curvature in the antrum, the greater and lesser curvature in the corpus, and in the incisura. Although in reality, very few of our clinicians follow this protocol, but this is the ideal one. And the gastroenterologists also, they take from the antrum, from the corpus, and even they do not send it in the same container. This is also they should ideally send it in separate containers so that we know exactly where the problem lies, but there is a communication problem. Now, to assess gastric biopsy, we need to see if there are neutrophils in the mucosa. The presence of neutrophils is indicative of active gastritis. We have to note whether there are features of chronic gastritis, which is denoted by lymphocytic and plasmacytic inflammatory reaction, which indicates the chronic gastritis. Basically, as in any chronic gastritis, the presence of plasma cells indicates a chronic lesion. Now, we also must know what is the topography of lesion, whether it is in the oxyntic mucosa or the fundus or in the antrum or involving the both locations. And one very important feature is presence of Helicobacter pylori. The moment we see Helicobacter pylori, the diagnosis, 80% of the diagnosis is done. Is there atrophy of the glands? Is there intestinal metaplasia? Or are there any special features such as granulomas, hyperplasia, viral influence? And sometimes there are ancillary studies which may be needed, the gastric function tests and their results. The main causes of acute gastritis are the drugs, like most commonly our non-steroidal anti-inflammatory drugs, the radiation, people with acute alcoholism. Now, multi-organ failure quite often results in gastric ulcers, or even any stress, burns, they all cause the stress ulcers. Uremia, certain foods, especially our highly curry foods. Portal hypertension causes gastritis, and septicemia causes gastritis. Alkaline reflux from the GI, from this small intestine, causes gastritis. And the pathology of acute erosive gastritis, in the acute phase, we find the vascular engorgement. The blood vessels, they are filled up, and there are small hemorrhages can be seen in the lamina propria. There is superficial necrosis. Polymorphonuclear leukocytes can be seen in the pits and glands, and the ulcers and erosions can be seen in the superficial layers. And we also see the numerous fibrin deposits at, you can see where my cursor is, we can see a lot of fibrin deposits. In the healing phase, we get the epithelial regeneration and nuclear enlargement. This is sometimes we mistake it with some dysplasia, and there is elongation of pits. There is a depletion of the mucous glands, and we also see a lot of mitotic figures sometimes in the pits. The H. pylori associated gastritis, there are various patterns of inflammation. We get the acute gastritis with marked neutrophilic infiltrates in the neck region around the lamina propria. There are pit abscesses. There is something known as pit abscesses, and there is desquamation of the surface for foveolar cells, and the regenerating cells, they form a multicellular layer, as can be seen here, with indistinct cellular borders, and creating syncytial polypoid excrescences. The cells, they join, the cell membranes cannot be differentiated. In the chronic active variety, we get a lot of plasma cells and lymphocytes in the lamina propria, and in the regenerative pit basis, we find the mucin cells are lost. There is cytoplasmic basophilia and increased number of mitosis. The hyperchromatic nuclei, sometimes they are seen and they mimic dysplasia. However, basement membrane is not penetrated. And in the chronic superficial, there are two varieties of chronic gastritis, the active one and the superficial one, in which we don't have much of inflammation, and there is no edema or vascular congestion. The epithelium is normal. Only the lamina propria, it contains large number of mononuclear cells. In chronic atrophic gastritis, we find the lymphoid aggregates located deep in the mucosa and in the muscularis mucosa, and there is sometimes a few granuloma cells, the granulation tissue epithelioid cells, they are sometimes seen. And also there is a diffuse antral gastritis characterized by intense antral mononuclear infiltrate consisting of mature lymphocytes and plasma cells. Now, the H. pylori is the hallmark of gastritis, and the severity of the H. pylori gastritis activity may be indicated in the pathology report as mild, moderate, and severe. Mild when we see the rare neutrophils, moderate when the obvious neutrophils within the glandular and foveolar epithelium are seen, and severe when numerous neutrophils with glandular microabscesses and mucosal erosion or frank ulceration is seen. Now, if you see in this slide, these inside, can you see on H&E staining, these are small H. pylori. We need some special stains sometimes, Giemsa stain or Diffquick stain or Warthin-Starry stains. These are the H. pylori. If you have a very good microscope, then the spiral shaped H. pylori are also, I have personally seen them even on a good Nikon variety of microscopes, however they can be obscured by mucus. The Warthin-Starry stain, these are the H. pylori, and here you can see on Giemsa stain the H. pylori inside the lumen. These are the H. pylori. Now, chronic gastritis there is chronic, the etiology is chronic alcoholism, increased age, old age people have chronic gastritis, and there is a smoking, there is reflux of bile and alkaline secretions, the autoimmune injury, the hypersecretion, gastric secretion, environmental factors including diet, Helicobacter pylori infection, and all these, they form the etiology of chronic gastritis. In North India, where we get a lot of alcoholism, an important cause of chronic gastritis. The various types of chronic gastritis are diffuse enteral, the fundic and multifocal, which progresses to multifocal atrophic gastritis. The term atrophic gastritis is defined as loss of appropriate glands. There is glandular loss, there is metaplasia. When it involves more than 50% of the total area of the gastric biopsy material, then we can call it atrophic gastritis. The assessment of atrophy is the ratio of, is done with the help of ratio of the glandular length to total mucosal thickness, the proportion of the secretory compartment area occupied by glands, and the number of glandular activity, number of glands across the cross sections per high power field. So in this field, if you can see 3 slides, that is mild atrophy here, you can see that there are a number of glands which seem quite viable, and the coils, they are resulting from the branching of each foveolar channel and are decreased in number with a concomitant expansion of the interglandular connective tissue. Here you can see the connective tissue, this is increasing. In the moderate variety, the number of the glands are quite villi, they are quite widened, and the intermediate, the amount of the interglandular connective tissue, it has increased quite a lot, and this is the intermediate variety. And in the severe variety, the coils are almost decreased. It is the complete flattening, and the glandular coils are completely replaced by fibrous tissue associated with minimal inflammation. Now, indefinite for atrophy, whenever inflammation prevents a clear distinction being made between non-atrophic and atrophic phenotypes. Now, metaplasia in gastritis, there are basically 5 major types of metaplasia. That is the pyloric, intestinal, pancreatic, ciliated, and squamous metaplasia. In pyloric metaplasia, or the pseudopyloric, also known as the pseudopyloric metaplasia, it most commonly occurs in the setting of the autoimmune gastritis. That is when there is a non-Helicobacter pylori type of gastritis. There is loss of specialized cells in the oxyntic mucosa and are replaced by a simpler glandular epithelium. Pyloric metaplasia first affects the glands closest to the antral junction, producing an antral expansion at the expense of the oxyntic mucosa, and the intestinal metaplasia begins at the antral corpus and in a patchy and multifocal fashion, and then spreads both distally and proximally to involve the antrum and fundus. There are basically 2 types, the type 1 which is complete and type 2 which is incomplete. Now, this is the type 1 metaplasia which is complete, and we can see the appearance of, in this slide we can see the appearance of mucin negative absorptive enterocytes with brush border with lot of, you can see the number of goblet cells has markedly increased. Here you can see the brush border on a higher magnification, and you can see numerous goblet cells are present, and here the Alcian blue periodic acid skiff staining is done, and you can see the goblet cells are positive for Alcian blue staining, and the gastric mucosa is staining red, indicating that neutral mucins are present. The acidic mucins of intestinal metaplasia are blue. Now this is the type 2 or incomplete metaplasia. Here the columnar cells containing the mucus droplets in their cytoplasm. The metaplastic cells lack a well-developed brush border. You can see here, and they secrete sialomucins and sulfamucin, and there is high amount of iron and Alcian blue. The ciliated cell metaplasia, in this the ciliated cells line the cystically dilated glands and represent an adaptive mechanism aimed at expelling the semi-fluid viscous material and inflammatory cells from the cysts. These are numerous cysts are formed in the lamina propria, and they are present in the mucosa of the patients with gastric ulcers, dysplasia, adenocarcinomas, or at sites of the main lesion. The pancreatic or acinar metaplasia is present in 12% of patients with autoimmune gastritis. The metaplastic foci contain single or multiple pancreatic nests with imperceptibly they merge with the gastric glands. The layers of smooth muscle cells that circumferentially surround the ducts in the heterotopic pancreas are absent. Now, there are guidelines for grading the different histopathological changes in gastric biopsies. That is the revised Sydney classification. Now, Sydney classification came in 1998, and after that there was not much revision, except there has been some mild revision in 2008. There are grading definitions and grading guidelines for each of the histological features to be graded in the Sydney system. In chronic inflammation, it is called chronic inflammation when there is increased number of lymphocytes and plasma cells in the lamina propria, and there is mild, moderate, or severe increase in the density. Activity when the neutrophil infiltrates of the lamina propria pits or surface epithelium, they are filled with neutrophils. We say the activity is increased. And for grading guidelines, that is less than 1/3 of pits and surface are infiltrated. It is called mild grade. The moderate grade is 1/3 or 2/3, and more than 2/3 is severe grade. The atrophy it is called atrophy when there is loss of specialized glands from either the antrum or the corpus. And the grading guidelines are again mild, moderate, or severe loss, depending upon how much there is loss. The intestinal metaplasia, when there is metaplasia of the epithelium and less than 1/3 of the mucosa is involved. 1/3 to 2/3 is called moderate, and more than 2/3 is called severe. If we see Helicobacter pylori, then the density of the Helicobacter pylori is measured, and if there are scattered organisms covering less than 1/3 of the surface, it is called mild colonization. Large clusters or a continuous layer over 2/3 of the surface is called severe, and intermediate numbers is called moderate colonization. Now here you can see the visual analog scales. For H. pylori, this is the normal without any H. pylori. Mild, occasionally we see the H. pylori here. The moderate when the H. pylori are lost, and marked when the H. pylori are completely lost, are increased. The neutrophils, again, they are mild, a few neutrophils, moderate when the neutrophils are increased, and severe when the neutrophils are markedly increased. The mononuclear cells, again, normally occasional mononuclear cell is seen, and the mononuclear cells can be increased according to mild, moderate, severe. In the atrophy of the antrum can be normal, mild, moderate, or marked. Atrophy of the corpus of the stomach can be, the number of glands is increased. In the mild variety, the number of glands is decreased, and as we go from moderate to severe, number of glands is decreased successively. There is intestinal metaplasia when the glands are columnar cells are replaced with goblet cells in the kidney system. The other forms of gastritis, there is reactive gastropathy when the changes limited to the antrum and prepyloric area can be seen, and there is marked foveolar hyperplasia. There is elongation and tortuosity of the gastric pits resembling a corkscrew, and there is depleted mucin. The smooth muscle proliferation and vagus congestion in the lamina propria can be seen, and there is paucity of the inflammatory cells. In iatrogenic gastritis, also known as the iron pill gastritis, as it is caused by, they say it is caused by taking the iron tablets in excess. There is a mucosal erosion. There are regenerative epithelial changes, and golden brown pigments can be seen. You can see near the cursor. The granulomatous gastritis, commonest cause is the Crohn's disease. There is sarcoidosis in 10%. There is H. pylori, which causes granulomatous gastritis, bacterial, fungal, parasitic infections, foreign body granulomas, or quite often in many cases there is no etiology, and the granulomatous gastritis of the uncertain etiology can be seen. Gastric Crohn's disease, that is an extension of the Crohn's disease in the small intestine. We can see granulomas, focal active gastritis, focal lymphohistiocytic clusters admixed with acute inflammation. Autoimmune gastritis occurs when there is the histological findings limited to the body and fundic mucosa with normal enteral findings. The chronic gastritis with prominent lamina propria and lymphocytic and plasma cell infiltration directed at the oxyntic glands can be seen. There can be loss of oxyntic glands, that is chief cells and parietal cells. You can see in the fundic mucosa, the lamina propria. Here there is a lot of collection of a lot of lymphocytes and plasma cells, and if we have a high part of this, we will see the loss of the chief and parietal cells, and there is a pseudopyloric metaplasia and intestinal metaplasia and pancreatic metaplasia. Lymphocytic gastritis is another term when there are more than 25 lymphocytes per 100 epithelial cells. The lamina propria is also expanded by lymphocytes and plasma cells, and there are foveolar pits which are slightly tortuous or elongated, and areas with erosions may contain active inflammation with neutrophils.